Now with Iatrix Systems. I will be your moderator today. Healthcare is a complex and highly regulated industry with data spread across multiple systems and technologies. Every day, healthcare decisions are made without having complete information readily available. Iatrix Systems is dedicated to leveraging our integration experience in order to provide products and services that bring the right data to the right people at the right time. For the past 25 years, we have delivered more than 25,000 interfaces and integration solutions to 1,300 healthcare organizations. This integration experience helps healthcare organizations make more informed decisions critical to improving patients' health and organizations' financial stability. Thank you for taking the time to attend our presentation, 3 Ways to Overcome Your Interface Challenges. Our speaker today is Rich Murphy. Rich is Vice President of Interface Software at Iatrix Systems. Rich has a Bachelor of Science degree in Engineering, a Master of Science degree in Computer Science, and more than 15 years as a healthcare IT professional and integration strategy expert, in addition to being an experienced programmer. He joined Iatrix Systems in 2003 to oversee interface development, implementation, support, and day-to-day operations. Now I will turn it over to Rich to get us started.
Thank you, Amanda. Wanted to thank everyone for joining our webcast here this afternoon. Today I'd like to discuss some key ways for you and your team to overcome some common interface challenges that we see. In today's hospital IT environment, interfaces are critical to your hospital's efficiency and ability to provide timely, quality patient care. I frequently hear customers struggle to keep interface projects on target, and some of the reasons range from their team is tied up on higher profile projects, for example, meaningful use initiatives, to they just don't have the in-house programming staff to create complex interfaces. I'd like to discuss some of the more common IT barriers that we often see and their impact that these have on the larger project planning and implementation. And I'd like to then review 3 ways to overcome these top challenges and what we're hearing from our customers. First, wanted to take a quick look at some information gathered from some industry-wide surveys. In the 2014 HIMSS Leadership Survey, respondents indicated that the lack of financial support and staffing resources continue to be key barriers to implementing IT solutions within their organization. 19% of those who responded indicated that lack of adequate financial resources and budgetary considerations was a barrier, and 18% indicated that a lack of staffing resources was a barrier. Both of these barriers were also indicated as top items and barriers in the same 2013 survey as well. A 2014 Healthcare Informatics Interface Survey took it a step further to find out what the top barriers are to being able to complete specifically interface projects on time. The 3 main barriers were identified as other projects taking higher priority, meaningful use specifically was called out as a specific barrier, and capital, resources and capital to implement, lack of technical staff to get the interfaces implemented as well. There is a way to stay within your allocated budget for your high-profile projects and complete these important projects on time. You can even protect your interface projects if you lose a key IT staff member, for example, due to retirement, or have difficulty finding new staff who understand your needs and the healthcare industry integration needs. We can help by sharing 3 suggestions from our experience to help you overcome your top interface challenges. Before we get into these 3 areas, just wanted to take a quick look at the ramifications and the consequences that we see if interfaces aren't working properly. When interfaces go down and systems stop talking to each other, some of the consequences can be caregivers cannot quickly access vital patient clinical data, clinicians needing to resort to manual patient care processes and downtime paper-driven type of workflow. Patient safety can also be jeopardized when information is not available to clinicians when needed. This can also lead to things like irate physicians and caregivers, bad publicity for the hospital, And we can also see that when things go down, that can lead to non-compliance, which can bring potential fines and penalties as well. The first way to overcome these interface challenges, like many things in life, is to have a solid plan. From the Healthcare Informatics Survey, 34% of those surveyed said that they only have a quickly sketched out or informal plan. Hopefully you're in the 61% who do have a clear and decisive, well thought out formal plan for each project. But if you're on this call, maybe you fall into that 34% who only have a quickly sketched out or informal process and plan. We find that there is a direct connection to having a solid plan and completing your projects on time and on budget. From the same survey, the majority of those who responded and indicated that they had a formal plan in place also completed their projects on time, while those that had an informal process and plan only sometimes, rarely, or never finished their projects on time. This can have a big impact on your department, patients, and your other IT priorities. With that in mind, let's take a look at the steps needed to put a solid plan in place for these types of projects. Because of unique requirements per system, varying specifications, and unique and hospital-specific workflows for each organization, we like to say that, if you've seen one interface, you've seen one interface. Really what we mean by that is that even when we're dealing with the same specs or vendors or systems, no two interfaces in our experience are exactly the same. Each will need to be coded to meet each hospital and organization's specific requirements, oftentimes different but similar workflow, and even similar interfaces can have subtle differences. While every project varies, there are several consistent steps to bringing an interface up and keeping it there. First, understand and document the workflow, meaning interfaces are going to be set up to connect disparate systems. Understanding how the end users are going to use these interfaces and the disparate systems on both sides, understanding that workflow will help ensure that you have the best possible plan in place. Review of the systems being connected, so having an understanding similar to item number 1 of what are these systems that we're connecting, how are people going to use them, what are the systems designed to do. Next would be the actual interface build and testing. This can be either point-to-point interfaces that are designed to connect two systems to each other, or interface engines can also be used and leveraged to connect, potentially feed the engine with a source feed and connect multiple similar downstream systems, for example. After the interface build and testing phase would be the go live, moving everything in the production environment and making sure everything works properly the day of the go live. And then we get into sort of the longer term monitoring and troubleshooting. And what we typically find is that items not typically found during the interface build and testing phase, which can happen, this is when those issues tend to appear. After the interface goes live, usually within the first days or weeks after an interface goes live, or when your obvious things that weren't found in the testing are going to pop up. Even after an interface goes live, item number 6, keeping up with changing requirements. So for example, even when interfaces are live and they're working properly and everyone's happy, third-party vendor software can be updated. Each vendor releases updates from time to time. HIS systems can go through scheduled or unscheduled system upgrades. So even when an interface is up and running, there will be some time required to keep it that way due to changing vendor and system requirements. And lastly, data mapping. What we find is that values between disparate systems may need to be mapped for the information to flow properly. For example, home medications. Home medications in one system might not necessarily match the home medication, the same values in the hospital HIS system, for example. They might not be codified in the ED system, but they need to be codified to go into the hospital system. Data mapping can help alleviate that and can be used to map, take those values from the one system which don't match and get those to match up with what the hospital is expecting. But for the hospital's team, even after an interface is live, the hospital team typically has to maintain and keep those mappings going forward. Second way to overcome your interface challenges is to be prepared to address unforeseen issues as these come up and arise. You might fall into one of these categories here as well. Top responders indicated that their top barriers are meaningful use. We mentioned that here a few times already. Still quite a top challenge for many of our customers. And other IT projects just having a higher priority. I'm sure everyone on this call can relate to the need for meaningful use and the drain that has on staff and budget and resources. Lack of technical resources and vendor delays were also marked as top challenges on integration projects. Some strategies that we see our customers taking to try to overcome these top challenges, the meaningful use lull. So right now we're seeing many hospitals have already attested for meaningful use stage 2. The requirements for meaningful use stage 3 are still in the comment phase right now, still being finalized. We have a rough idea of what stage 3 is going to entail, but until the requirements are actually finalized and set in stone, we're still in that comment phase. So what we find is that this is a good time. Many of our customers are taking care of, back burner projects, sort of pet projects that might have taken the back burner due to meaningful use. Now's a good time to get in there and get those projects wrapped up and completed before the focus then shifts towards meaningful use stage 3. And for those projects, a high-level prioritized plan really will help your organization see which projects, again, above and beyond meaningful use, need to be addressed in the order of top priority. Next, we want to look at the lack of technical staff. As you take a look at your technical staff, review your team's technical abilities to determine which work you want to choose to do in-house and which work makes sense to have somebody else take on and tackle. And, a key point is you really do need to be honest with your internal evaluation. If you don't have the programming resources to take on a complicated interface build, you might want to be honest and just call it that, so that then you know that that's an area where you might have to pull in an outside vendor, interface type of provider to help out there. Project management, what we find is a strong project manager assigned to keep the projects on target and on timeline is a solid way to help guarantee that each project is completed on time and on budget. I mentioned a few moments ago about looking at your in-house team's abilities. So just some additional considerations. Let's look at that in a little more detail. When evaluating your staff's abilities to tackle integration projects and see those through to a successful completion. Disparate systems. So, barriers between disparate systems. Does your team understand the data and workflow differences between the different systems being integrated? So for your team to successfully create the interfaces to bridge disparate systems, your team's going to have to know the workflow in both systems to be able to best bridge those two together. Typically, the actual act of building an interface, we find that interface engine experience and HL7 experience and comfort level are required to properly create and execute these interfaces. Adding integration project items to an existing staff can also potentially cause other projects to fall behind due to increased workload. Your team having the time to build and manage these multiple interfaces at the same time. Teams can only do so much work in a given week or time frame, and adding additional projects to maybe an already stressed out and maxed out team is going to cause other items to sort of fall by the back burner, which might not be the intent. As far as support, as you're looking at your team, what's your team's availability off hours 24/7 to respond to technical emergencies with interfaces that potentially you've created? So if an interface goes down off hours, what's your team's ability to detect that, potentially see alerts and receive alerts, and be able to get connected in and address and correct the issues? I mentioned a few moments ago when interfaces go down, some of those consequences. You need to look at your team's ability to manage those high-risk interfaces and the high risk to patients and your facility when interfaces stop working. So for all of the interfaces that your team is going to choose to create yourselves, you're also taking on that off-hour support and the risk associated to that. And last but not least, there's the cost, justifying the high cost of building and managing an interface team in-house. To have the staff in-house to be able to do these interface projects, you have to also have the staff typically on staff full-time, and that does come with a cost. Even when the team's not building interfaces, typically you're going to tend to still need them there. The third way to overcome your interface challenges is to ensure that you have proper interface expertise in place. What we find is that many healthcare IT groups find that they just don't have the time or manpower to tackle integration projects in-house. Some of the options available to your organization are you're doing all the work, performing all of the work in-house with your own team, or hiring an outside interface service provider to manage all of your interface projects, or a combination of the two, sort of a blended approach. We find that this is pretty common with our customers. A lot of our customers selectively choose to do the more straightforward and easier interfaces that they have the time and the staffing and the expertise to be able to tackle, but then outsourcing and having an interface service provider do the more, the moderate to difficult projects that they just don't have the team, the staffing or the comfort level to do in-house in the hospital. And we do have customers who successfully used each of these above approaches. And one thing that we find is, as we all know, it is difficult to find the right people when needed. From the Healthcare Informatics Survey, 62% said that they struggle to find people with healthcare IT integration experience. Some additional considerations there are the hiring process. Hiring process can, at times, take a while. Even when you find the right candidate, it can take a while to go through the interview process, select the right candidate, make the offer, go through the entire HR process. Sometimes it can take months. And that process can be time-consuming, especially if you can't find the right people to get the job done and when you might be up against very firm and strict go-live dates. Interestingly, the same survey indicated that 62% of responders also indicated that they had hired external resources to help with their interface projects. Some additional considerations when you're taking a look at your in-house team's abilities to do this work internally in-house. Do you have the staff to accomplish the project on time without putting other projects off and jeopardizing other potentially higher profile projects, higher priority projects? Can you cost effectively coordinate these activities in-house? Should you use an interface engine? If so, which interfaces are best used through that engine and which makes sense to do as point-to-point? So knowing when to leverage that engine. There are some specific scenarios where actually point-to-point might be a better choice. So knowing which interfaces are best to go through the engine or which are better to go point-to-point is something that you'll have to manage in-house for any that you choose to create in-house. What's your internal level of interface expertise? We're finding that more and more definitely a knowledge of HL7, version 2.3 is required. With meaningful use, we're finding that detailed knowledge of HL7 version 2.5.1 is required. We're also finding with meaningful use stage 3 things like HL7 Fire, which is another HL7 item that we're seeing more and more of. Just what's your team's internal level with all of those, because those are probably going to be required to actually do the interface builds in-house. Can your team monitor these interfaces 24/7, 365? So again, having that ability and the team to be able to monitor this. Creating the interface is the first part, but being able to monitor and make sure everything continues to run. And scaling. Can your IT team scale up and scale down to meet changing project demands? So if your team is already tapped out and saturated, do you have the ability to add additional projects, sometimes stressful, date-driven projects? Does your team have the ability to take those on as well and scale up? And as far as regulations, I mentioned meaningful use a moment ago. What's your team's in-house knowledge of regulations related to the exchange of patient data? Meaningful use, for example, we had some customers who elected to create their own interfaces for meaningful use stage 2, and they found out, unfortunately, they were able to overcome it, but it definitely caused them some stress and anxiety. They found out about halfway through the process that they needed certified interfaces for, in this specific example, exchanging data with their state public health agency. And they only found out when they were halfway in and many hours in of having their in-house team do those that their interfaces weren't going to work because they weren't officially meaningful use certified. And to get those certified, it was actually going to cost them more than had they gone out and just purchased those interfaces from an outside company in the first place. So that came up due to the regulations and the specific requirements of meaningful use. So your team's going to have that knowledge. What's your team's comfort level of those regulations? And again, as we're looking at stage 3, additional regulations and specs that need to be met and conformed to. Knowing this and taking a look at that, if you decide that you don't have the staff or the time or the budget to take on integration projects in-house, you might find that you're in that 62% bracket of people who decided to seek outside help. Interface service providers can help take the burden off of any of these tasks. They can help in such areas as handling full-time project management from kickoff through completion, getting that project from the initial scoping and kickoff call through the completion and the off-hours monitoring, assisting with data testing and data entry. For example, once the interface is built, the testing phase at times can be somewhat time-intensive, can have time-intensive data entry needs and requirements. Outside vendors can assist with some of those data entry needs if needed. Outside interface companies can also help you leverage experience with existing vendors, vendor partnerships, HIS systems, and database knowledge and comfort level. Leveraging experience with similar integration projects. So I mentioned, for example, that meaningful use interface for stage 2 to the state's Department of Public Health. An interface, a hospital might only be doing 3 of those for meaningful use, or 1, 2 of those for meaningful use. But for an outside interface vendor, that's what they do every day of the week, doing those same exact public health interfaces for other hospitals in your same state, for example. So taking advantage of that experience that often is sort of hard-fought and, hard-earned experience, outside vendors can have that experience. Interface monitoring and support during normal working hours and off hours. An outside interface provider can help by providing sort of that additional beefed up staffing, a beefed up team to help you with that off hours monitoring so that your in-house team doesn't have to do all of that themselves. And also, being flexible to your organization's sometimes changing needs. Needs change, priorities change, and having a strong vendor partner to help you create and take on this interface work can help you, with changing dates, changing timelines, and changing needs at times. Tapping the experience of an outside provider brings many benefits. It can be more cost-effective to complete each project by having the outside vendor focus specifically on what they do and honing that knowledge and experience that they have. It can help minimize the risk to your hospital when employees leave or retire. For example, we have had several customers over the years come to us, and in some cases panicking, where an in-house resource was on their team for many, many years, created quite a few interfaces, and really was the only resource that knew how those things worked in-house, and that resource was now retirement age and was going to retire. So in that case, or in each of these cases, IATRIC was able to help by interviewing the hospital and finding out what these specific interfaces that we didn't create do, and we were able to help insulate that hospital from any downtime or patient issues or things like that due to that staff retirement. Outside interface vendors can also help shorten implementation timelines. Taking integration projects live is what interface companies do every day of the week, and it's really what they're comfortable with. You can also potentially achieve higher quality deployments, not to take anything away from in-house resources who might be creating interfaces for your organization. But again, interface vendors who do this day in and day out, you can potentially achieve higher quality deployments because the lessons learned on one project are rolled into the next project for the strongest possible code. You can also reduce the risk of interface project build and failure. and even, rest easy, even on the holidays with dependable off hours, 24/7, 365 support. Again, instead of the hospital taking that all on your own team's shoulders, which, the team is only so big, kind of outsourcing that and having an outside interface vendor help just increases the number of people who can help with that, potentially with that off-hour support, which should lower your team's stress level as well for that off-hour support component. I did want to take a few moments to look at two specific interface projects where our customers were able to overcome some of these issues that I talked about here today. First, wanted to take a quick look at St. Luke's. St. Luke's Hospital is located in Duluth, Minnesota. They are a Meditech hospital. They currently have 38 physician practices with over 215 physicians, so good size there. They're using eClinicalWorks as their physician office EMR system. And the hospital came to us a while ago with a few specific needs. They wanted to be able to pass patient orders from any of those practices out there in the community back into the hospital system with no delays. They wanted that to be real-time, electronic, no delays. They were using a fax and paper-based approach prior. They wanted to pass the correct patient results to each practice as those are entered in the hospital system, real-time, again, electronically. And they wanted to allow their patients to receive care at any of those 38 practices in the community, and wanted the patient's information shared real-time with all of those practices, so the patient could basically go to any of those practices and receive the care at any practice that they wanted. Our team was able to work with the hospital and was able to help them overcome these challenges in a few different ways. The customer was not going to have the in-house bandwidth to be able to create the interfaces themselves. We found that, and the hospital found that IATRIC also had, fortunately, had quite a bit of experience with that EMR vendor. We had done many projects and had many successful go-lives with that same EMR vendor, and in this case, actually had main points of contact on the EMR vendor side that we do repeatable work with. So we had a definite comfort level there with that EMR vendor. We created bidirectional integration between the hospital and each physician practice to provide real-time, secure information exchange. This allowed each practice and the hospital system to be synced up electronically real-time, so no more need for faxing and chasing down papers or having patients have to manage the paper and bring that piece of paper into the hospital. This allowed each practice and the hospital to have that real-time HL7 data transfer. For this specific project, we've integrated with over 75 different EMR vendors, and this particular EMR vendor was one of those. And the work was coordinated between the hospital, IATRIC, and the various practices to make the process as seamless as possible with each practice. And where each practice was using the same EMR vendor, we found that there was a lot of repeatability. Once we had it up and running with the first one or two practices, and the hospital had communicated exactly what they wanted to us and the various practices, we were able to basically copy what we had done for those first couple practices so that the third and higher implementation went a lot easier. Same basic workflow and practice management workflow each time. We were also able to add some custom programming, which wasn't on the table when the project first started, but during the implementation, the hospital came to us with an additional need. They wanted to bring physician notes back into the hospital system, and they didn't even realize they needed that until the project had actually started. So we were able to, after the project started, bring those physician notes back into the hospital's Meditech system. I next wanted to take a quick look at our second hospital here, Roper St. Francis. They're a private, non-profit health system located in Charleston, South Carolina. Roper approached us to assist with integrating their third-party ED system with the hospital HIS system. And those are two systems, third-party, outside ED system and the hospital system, which do not typically interact or integrate with each other, natively. We did create real-time bidirectional data integration between the ED system and the hospital's HIS system. And by the hospital's estimates, this saves them an approximate 5,000 hours of staff time annually. That was time that their team previously spent searching for information between those two systems. manually, to provide the proper patient care. As an added benefit, the electronic information sharing between the ED system and the inpatient system helps eliminate the risk of medication errors when patients were admitted into the ER, because all the data was transferred electronically, and we did put some of that mapping in that I talked about a few moments ago. That helps significantly reduce the hospital and the patient's risk of medication errors. Some additional benefits included automatic updating of the patient's record across multiple systems, improved data collection for meaningful use compliance, and happier physicians and nurses because the information they need is now right there at their fingertips, in this case within the ED. In closing, we presented 3 ways to help you and your organization overcome your interface challenges. If you have any questions or want to talk to your specific situation to see how IATRC might be able to help, please don't hesitate to contact me. I'm interested to hear how IATRC can help. And with that, wanted to thank you for your time today. And Amanda, wanted to turn it back over to you.
Thank you for listening to this webinar today. Please be sure to follow us on LinkedIn, Twitter, Facebook, and Google+ for up-to-date product information and announcements. If you would like more information, please contact your IATRC Systems Account Executive, or you can send an email to info@iatric.com. This concludes our webinar.